Okay, I see people are actually still coming in, but let's get started. My name is Melissa Rosen. I am the Director of Training and Education at Sharp-Sherritt, and I want to thank everyone for joining us tonight for managing cancer care during COVID. I love that tonight's webinar is actually two programs in one. Just as our country is beginning to face the implications of another wave of COVID-19, Dr. Stephen Peskin is joining us and will be speaking about maximizing telehealth appointments. And while we're still in open enrollment, we have with us tonight Joanna Morales, who will explore with us the options we have when choosing insurance and some of the things to consider with regard to cancer treatment as well as COVID. Before we begin though, I wanted to share a couple of housekeeping details. I want to let you know that this webinar is being recorded and will be posted on Sharp-Sherritt's website along with a transcript. Please note that no participants' names or faces will be part of the recording. You may have noticed that all participants were muted upon entry. We recommend that you stay that way. We ask that you stay that way, but we recommend you keep your screen on speaker view. This will enable you to see the presentation clearly. You can find that option in the upper right-hand corner of your screen. I want to tell you that we received so many impressive questions before tonight, and I expect additional questions now. So please use the chat box as we go along, which you can access on the bottom of your screen, and we will do our best to answer as many questions as possible. I do want to take a moment to remind you that Sharp-Sherritt has been providing telehealth services for the breast and ovarian cancer communities for just about 20 years now. And although we could never have imagined the world as it is right now, through our services, we've been preparing for this moment and continue to be there for you each and every day. In addition to the many formal programs to help women and their families navigate different aspects of the cancer experience, I want to remind you tonight that our clinical social workers are available every weekday from 9 to 5 in every time zone for one-on-one support. They can answer questions, connect you with appropriate resources, allow you to vent on a difficult day, and so much more. As always, our support services are 100% confidential and 100% free. As we move into the webinar itself, I also want to remind you that Sharp-Sherritt is a national not-for-profit cancer support and education organization. We do not provide any medical advice or perform any medical procedures. The information provided by Sharp-Sherritt is not a substitute for medical advice or treatment for a specific medical condition. You should not use this information to diagnose or treat a health problem. As always, seek the advice of your physician or a qualified health provider with any questions you might have regarding your situation. Okay, let's get to it. Today's presenters have a wealth of knowledge and unique skills. Joanna Morales is a cancer rights attorney and the CEO of Triage Cancer, a national nonprofit organization that provides education on practical and legal issues that may impact individuals diagnosed with cancer and their caregivers. Ms. Morales has spent more than 25 years working in the cancer community, including as an adjunct professor of law at Loyola Law School, teaching cancer rights law, and for the John Wayne Cancer Institute Psychosocial Care Program. She has presented hundreds of seminars, and I've been to them and they're wonderful, on employment, insurance, finances, advocacy, and she's co-authored a book on cancer rights law for the American Bar Association. She's published in many different periodicals and is going to be speaking tonight about insurance concerns with regard to cancer and COVID while we are still in open enrollment. So, Joanna, would you please join us? We're going to spotlight you now.
So, hopefully you can see my slides.
We can.
Awesome. So this is sort of a stressful time to navigate health insurance. We have a pandemic that makes people more concerned about having and keeping health insurance. We have an economic environment that makes it more likely for someone to lose their employer-sponsored health insurance coverage. And then you add in an election season that could have very significant impacts on access to healthcare and our health insurance coverage. And then on top of all of that, we have a case pending in the US Supreme Court that could have an impact on pretty much every aspect of our healthcare system. And it's a lot to process on top of a cancer diagnosis and the health insurance challenges that come along with that. And so it is open enrollment right now for Medicare, for individual marketplace plans, and for many employer plans. So my goal is to give you a few tips on how to navigate your insurance options, your coverage, and where to go for more information. So in the United States, there's only 3 places where we get our health insurance coverage. We're either getting it directly from an insurance company, we're getting it through the government, and by that I mean Medicare, Medicaid, military and veterans plans, state and local programs, but still about 50% of people get their health insurance coverage in the United States through an employer. The challenge in talking to people about their health insurance coverage is that most people don't understand our healthcare system or health insurance in general. So if you feel like you don't have a good grasp of your health insurance coverage, you are absolutely not alone. The majority of the country doesn't have a high rate of health insurance literacy. So to make sure we're all on the same page, these are the terms that we think are most important for people to understand about their health insurance coverage. The first is our monthly premium. It's what we pay each month just to have our health insurance coverage. If you get coverage through your employer, maybe your employer pays the premium for you. But there are some costs that we pay when we get certain types of care. And the first is our annual deductible. It's what we pay out of pocket first before our health insurance coverage even kicks in. And that's a fixed dollar amount. So you might have a $500 deductible, or you could have a $5,000 deductible, depending on your policy. And then there's something called a copayment. And this is also a fixed dollar amount that you pay when you get certain types of care. So you might have a $10 copayment to visit the doctor's office, or you could have a $40 copayment to see a specialist, or a $200 copayment to go to the emergency room. The amounts are going to depend, again, on your coverage. And then there's something called coinsurance or cost share. And this is a good example of where in health insurance, there's at least 2 names for everything, just to confuse us. So coinsurance and cost share is a percentage. It's the difference between what insurance companies pay for our medical expenses and what we pay for our medical expenses. So if you have an 80-20 plan, the insurance is going to pay 80% of your medical expenses and you're responsible for 20%. Now, I think the most important thing that anyone should know about their health insurance coverage is their out-of-pocket maximum. Because in a worst case scenario, it's the most that you're going to pay out of pocket during the year for your medical expenses. It is a fixed dollar amount, so you could have a $1,000 out-of-pocket maximum, or you could have a $20,000 out-of-pocket maximum, depending on your coverage. And the way that you get to your out-of-pocket maximum is a math problem. You get to add up what you pay for your deductible, plus co-payments that you make during the year, plus co-insurance amounts that you pay. And then when you reach that out-of-pocket maximum amount, then your insurance will kick in at 100% for the rest of the year. So it's an important number to know about your coverage and also to keep track of the payments that you make to help you reach that number. So to give you an example of how this works, Dan has a plan that has a $2,000 deductible. It's an 80-20 plan, and he has an $8,000 out-of-pocket maximum. And he has spent a week in the hospital, and he walks out with a $102,000 hospital bill. So assuming he's had no other medical expenses during the year, how much does he actually have to pay of that bill? Well, he has that $8,000 out-of-pocket maximum, so it's $8,000, but this is how you get there. First, he has to pay his $2,000 deductible, which leaves $100,000 left of that bill. But he has an 80-20 plan, so the insurance is going to pay 80% and he's responsible for 20%, which leaves him with the $20,000 bill. But how much of that bill does he actually have to pay? In this case, it's only $6,000 because he has the $8,000 out-of-pocket maximum. He's already paid a $2,000 deductible. So he needs to spend another $6,000 to reach his out-of-pocket maximum, and then his insurance will kick in and pick up the rest of that $20,000 bill. Now, I'm absolutely not suggesting that $8,000 isn't a lot of money, but at least it's a cap on how much you would have to pay out of pocket. Whereas if you didn't have a cap, that amount you'd be paying all year long for 20% of your medical expenses. So we're going to come back to this in just a minute when I talk about how to pick a health insurance plan. So everything I actually just explained is in one of our animated videos on health insurance. So if you think that that's a useful piece of information to share with other people, you can certainly pass that along. Now, there are some key consumer protections that are very important to individuals in the cancer community or to anyone with a pre-existing condition. And these two protections actually happen to be in the Patient Protection and Affordable Care Act, otherwise known as the ACA or Obamacare. And the first is that the ACA changed the way that health insurance companies decide how much to charge us for our coverage. And that process is called premium rating. Previously, insurance companies could look at whatever they wanted to when deciding how much to price a policy. And now they can only look at four things: whether or not you're buying a policy for an individual or family, because if you're covering more people, they can charge you more; where you live based on your zip code; your age, but they put a cap on how much more you can get charged as you get older. There previously wasn't a cap. And then if you use tobacco, you can be charged more for coverage. So what's missing from this list? Pre-existing conditions and gender. So women have always been charged more than men for health insurance coverage, and that's no longer allowed under the ACA. So then the ACA went one step further and said, we're not going to let insurance companies deny people health insurance coverage based on their gender, their age, where they live, their pre-existing conditions, or really any other reason. If you can afford the policy, they have to provide it to you. So these two things together mean that someone with a cancer diagnosis can't be denied health insurance coverage and can't be charged more because of it. And these are referred to as the pre-existing condition protections. And there's been a lot of conversation over the last couple of years about repealing the ACA, but saving the pre-existing condition protections. But most of those conversations have only focused on the second piece. But the second piece isn't really a protection unless it comes with the first piece, because it's not really a protection to say, I can buy a plan, but then you can charge whatever you want for that plan and then price me out of the market. So when we talk about pre-existing condition protections, it's really these two things together that make it so effective for the cancer community to get access to health insurance coverage. So the other consumer protection that I wanted to mention that's in the Affordable Care Act tonight is about the appeals process. If an insurance company denies coverage for treatment or a surgery or other type of procedure or prescription drug, you can appeal that denial and ask them to change their mind. If they still don't agree with you or your healthcare team for prescribing that particular treatment, you can now go outside of the insurance company to what's called an external appeal. And you go to an independent medical review organization through your state insurance agency usually, to take a look to see if the care that's been prescribed for you is actually medically necessary. And if that entity decides that it is, then the insurance company has to provide coverage for that care. I call this the best kept secret of our healthcare system because people tend to take no for an answer. And the challenge with that is that we know, based on data from 2017, there were about 42 million claims that were denied that year, but only 0.5% of those claims were appealed, which is a tiny fraction of the number of claims that were denied. But on average, individuals that go through the external appeals process have their decisions overturned about 50% of the time. So 50% of people whose claims were denied here were potentially able to get access to care that they either didn't get because they couldn't afford to pay for it out of pocket, or they paid for it out of pocket, which only increases the financial burden of a cancer diagnosis. So the appeals process is very important to know about because it is there to help consumers get access to the care that they need. Now, when talking about health insurance options, because of those pre-existing condition protections, we now have the ability to review our health insurance options every year to make sure that they're the best coverage for us and based on our medical needs. So I want to walk you through a quick exercise on how you actually compare your health insurance options. And this exercise works if you're comparing plans in the marketplace, if your employer gives you multiple choices, you can compare what your employer offers to the marketplace, and you can compare your Medicare plans using the same exercise. So here there are 3 plans. There is a bronze plan at $173 a month with a $6,000 out-of-pocket maximum. A silver plan with $271 a month in premiums and a $5,200 out-of-pocket maximum, and a platinum level plan that's $398 a month with an $1,150 out-of-pocket maximum. So assuming that you're going to hit your out-of-pocket maximum during the year, when we're talking about cancer care, that's pretty likely in terms of how much it costs. Can you tell just by looking at these plan options, which is actually going to cost you the least by the end of the year? And it's not a trick question. You can't tell just by looking at them. You have to do the math. And the way that you do the math for whichever plan choices you're looking at is that you take the monthly premium and you multiply it by 12 because that's how much it's going to cost you for the year. And then you add that to the out-of-pocket maximum. So in this case, the platinum level plan with the highest monthly premium actually ends up saving you a couple $1,000s by the end of the year because of that out-of-pocket maximum. But generally when we're shopping for coverage, we're only paying attention to the monthly premium because we don't understand how out-of-pocket maximums work, and we get sticker shock when we see that. But if you are smart about shopping for your plans and comparing your options, you can find plans that can save you thousands of dollars by the end of the year. And when we talk about how do we mitigate the financial toxicity of a cancer diagnosis, this is actually one of the best ways that you can do that by lowering your out-of-pocket costs. But it's not just based on cost. You have to make sure that when you're shopping for plans, you're comparing the networks of providers that are covered by that particular plan and make sure that your hospitals are covered and also that your prescription drugs are actually covered by that particular plan. Otherwise, it's going to be pretty useless to you. And the marketplace, as well as Medicare.gov, actually give you some tools online to be able to check this information. Now with Medicare, you have choices every single year as well. If you have a Medicare plan, open enrollment is from October 15th to December 7th every year, and you can drive back and forth between these 2 different types of Medicare coverage. There's original Medicare, and then there are Medicare Advantage plans, which are run by private insurance companies, excuse me, where they offer your Medicare coverage through a managed care plan. Now, that is probably the quickest overview of Medicare I've ever done. So if you have questions about Medicare and want more information about open enrollment and how to actually make some decisions about what type of Medicare coverage is best for you, we have a number of resources, including an hour-long webinar that we just did in September in preparation for open enrollment. So those are resources available to you if you have Medicare coverage. Now, Medicaid is the other federal health insurance program that's available to individuals who have a low income level, a low resource level, and meet other categories of eligibility. So there were these different doors into the Medicaid program, but the ACA actually created a new door into the program for individuals with a household income up to 138% of the federal poverty level, which this year for an individual is $17,609. So if you make under that amount, you can get access to Medicaid in your state. But the Affordable Care Act made it mandatory for every state to create these doors. But the Supreme Court got their hands on the Affordable Care Act once before, and they made it voluntary for states to participate. So these are the states as of today that have expanded access to their programs, and then the states on the right have chosen not to. The ACA also created state health insurance marketplaces. And the best way to describe these are like insurance shopping malls. So it's one place where you can go and find all of your private insurance options based on your state and where you live. But there are some benefits to actually buying a plan through the marketplace. One of which is that there is a cap on all the plans in the marketplace and what their out-of-pocket maximum is allowed to be. So this year it's $8,150. You can also potentially qualify for financial assistance to buy a plan through the marketplace based on your income level. So premium tax credits lower your monthly premiums, and cost sharing subsidies lower what you pay for your copays, your deductibles, and your coinsurance amounts. The last benefit to the marketplace is that all the plans sold in the marketplace are standardized by their cost share. So the lowest level of coverage is a 60-40 plan, which is a bronze plan. And the highest level of coverage is a platinum plan, which has a 90-10 coinsurance amount. So the benefit to that is that all the companies that sell plans in the marketplace have to sell them at these levels. And so you can actually compare apples to apples and oranges to oranges as a consumer. So this is what it looks like based on income level. If you have a household income up to 138% of the federal poverty level, you have access to Medicaid. If you're between 138 and 250% of the federal poverty level, you have access to both the premium tax credits and the cost sharing subsidies. And then if you're between 250 and 400% of the federal poverty level, you have access to just the premium tax credits. So all of that to say is that if you have a household of 4 making under $103,000, you're getting access to some type of financial assistance to buy your plan in the marketplace. And there are some states like California, which actually provide financial assistance between 400 and 600% of the federal poverty level. So if you're in a state that didn't expand Medicaid, like Texas, for example, you lose access to that Medicaid option, but you still have access to these other options if you have a higher income level. So there are only certain types of the year that you can actually enroll in coverage. And Marketplace open enrollment for 2020 is closed, but if you were to lose access to your health insurance coverage tomorrow, for example, you'd be eligible for a special enrollment period. That's a 60-day window to go up and buy a plan in the marketplace. But if you're shopping for marketplace coverage for next year, that marketplace open enrollment happens to be going on right now and will run through December 15th. There are some states that have marketplaces that will last longer for open enrollment. California would be an example of that. New York's usually runs longer because those are states where they run their own marketplaces. And we have that information on our website. Medicaid applications are accepted year round. And as I mentioned, Medicare's open enrollment will run through December 7th. Now, if you have employer-sponsored coverage, you have open enrollment every year as well. But when that happens depends on your employer's plan and when that plan renews. Most employers that have plans that start new on January 1st have open enrollment in the fall as well. So if that's the case, you want to check to make sure if you want to make changes to your coverage that you do that during open enrollment. I did just want to mention, because we know that many people have lost their health insurance coverage because they've either been furloughed or their businesses have closed, that COBRA is the federal law that allows you to keep your employer-sponsored health insurance coverage for up to 36 months. That's a great way to keep access to coverage, but the downside is that you are responsible for paying the full amount of what your employer was paying for that policy. And I always say we don't appreciate when our employers pay for our health insurance until we have to write that check ourselves. The thing about COBRA is that there are programs available to help people pay for their COBRA premiums. And that's information, again, that we have on our website. These are also one of those things that we call best kept secrets of our healthcare system that help people keep access to their employer-sponsored coverage. So now when someone does lose their employer plan, they have multiple options. So you could drive down the lane that gives you access to COBRA or your state COBRA law. You could buy a plan in the marketplace during a special enrollment period. You might be able to move to a spouse's group plan, or if you're a young adult and you're not yet aged out of your parents' coverage, you can move back to your parents' health insurance plan. And then you could also see if you qualify for Medicare or Medicaid in your state. So I know that this was a super fast overview of some of these options, but I promised I would show you where to go for more information. But because the key to some of these choices is that once you pick a lane, you can't change lanes. You're committed to some of these choices. So we want people to have all the details of the information that they need. And we do have a new quick guide and an animated video on your options when you lose employer-sponsored health insurance coverage. So Triage Cancer has a number of resources, whether they're print materials like our quick guides, as well as our animated videos on some of these topics. And then we also have state-specific resources and our chart of state laws that cover health insurance, employment, and many other topics. I do also want to mention that we have a resource called cancerfinances.org. One of the sections of this online resource is specific to COVID and all of the new legal protections under employment for consumers around student loans and housing, as well as financial assistance options are in that COVID module as well. So with that, I will turn it back over to Melissa.
Thank you so much. You made a topic that is very confusing, much simpler. And I have some very interesting questions for you at the end of the evening. But right now, if you could stop sharing your screen, yeah, which is happening this second, there you go. I want to introduce our second presenter for the evening. Dr. Stephen Peskin is the Executive Medical Director, Population Health at Horizon Blue Cross Blue Shield of New Jersey. His expertise encompasses physician leadership, population health management, clinical and operational performance improvements in healthcare, as well as medical education and scientific communications. Dr. Peskin is an associate clinical professor in the Department of Medicine at Rutgers Robert Wood Johnson Medical School. Among his many responsibilities, he assists with population health and business of medicine training for the Rutgers Robert Wood Johnson Internal Medicine Physicians in Training Program. He received his medical degree from Emory University of Medicine, School of Medicine, and completed his residency at St. Elizabeth's Medical Center in Boston. He also holds an MBA from the Sloan School of Management at MIT. I actually first got introduced to Dr. Peskin by reading an article of his on this very topic that he's speaking about, which is maximizing telehealth as it's becoming more and more common. Dr. Peskin, thank you.
Thank you. So I'm going to start tonight with a little story. We'll go back to certainly before Melissa was born and Yael and probably Joanna as well. It's 1967 in my hometown of Augusta, Georgia, and the phone used to ring pretty regularly. My father was a primary care general internist, which is what I am clinically, and am very proud of that, and precept in what's called a federally qualified health center, an FQHC in New Brunswick. So I had a phone on the wall with a long cord and a dial thing. Most people don't remember that, but it would sometimes wake me up at 2 or 3 in the morning. So my father of blessed memory, Herman, Max, how you doing? Why are you calling me? So this guy would call our house because we didn't have an unlisted number. He would call very regularly with really minor complaints, pain in the ass. And so my father was up one night, couldn't sleep. And so he decided to call Max and just said, I'm just calling to check in on you. So that's my earliest memory of telemedicine. So this is, what's old is new again. So physicians, clinicians, healthcare professionals, social workers, psychologists have been making phone calls to patients, persons for years. Sharsheret is, as Melissa said, has been providing remote, not practicing medicine, but providing advice and counsel for the better part of 20 years. But telemedicine has become very fashionable. So we at Horizon, during the darkest days of the pandemic, which unfortunately seem to be recurring, moved very quickly to expand our telemedicine capabilities with an organization out of New York that we work with. And just, I would say for the persons on this call, and I know there's some healthcare professional as well as patients and perhaps family members, telemedicine does provide a logical extension of healthcare. For example, I was talking to a physician this morning, and he said he had some genetic risk. He happens to not be Jewish, but is married to a Jewish woman. So he had a 20-page form he had to fill out at Rutgers and go to an office that was very hard to find. He said, if I had filled out that 20-page form online and had this conversation with this woman as we're having this conversation tonight on a screen, that would have been perfect. It would have saved 45 minutes each way driving. So clearly there are very, very appropriate uses of telemedicine. We know that, or most people on this conversation are probably informed that you can send information to your healthcare professional, whether it be from a thing like this. Here's my blood pressure cuff. I've also got a pulse oximeter, and so it's very facile. And I would say that the telephone was fine in the 40s, 50s, 60s, and now we have technology that allows us to do quite a bit more virtually. Looking at a rash, following up with a person with an ovarian or breast cancer survivor to check in on how she is doing. It makes a lot of sense. On the other hand, if one has a mass in her stomach or some disease, clearly not disease, but dis-ease, that makes all the sense in the world to be seen face to face and to have a physical exam. So there are a lot of different vendors out there in telehealth, companies like the brothers in Boston that started American Well, Teladoc, MD Live, Doctor on Demand. There are also a myriad of platforms that are used by some of the people on the phone, again, are healthcare professionals, Doximity, DoxyME, UpDocs. All of these tools work reasonably well to connect the healthcare professional with the person, whether you want to consider yourself a patient at the time or just someone, whether we call ourselves patient, person. And so that the ability to use something and with a liberalization under CMS guidelines during the SARS-CoV-2 pandemic, where we can even use Zoom and FaceTime without some of the guardrails around protected health information, PHI. So what we've seen is we had a very big surge in demand for telemedicine where it was less than 1% of visits, and during at least in the Northeast, the March, April, May period, it was in the 30, 40, 50, 60, 70%. Then it attenuated, and people wanted to be seen in person. And there certainly is, myself, a bit old school, the notion of being in the physical presence of someone. But if you on this call are concerned about exposure to COVID, which is certainly a very reasonable concern, and you can interact with your healthcare professional, whether she be a physician or he be a nurse, then I would say, from my point of view, telehealth can be a very powerful, effective adjunct to care, and is something that certainly has advanced and evolved. You as, and again, I know everyone on the phone is not a patient, there's some healthcare professionals on, but if you are a patient, I would say certainly as you think about preparing for your telehealth visit, in much the same way that you would prepare for a physical visit, makes a lot of sense to get the most out of that interaction, to optimize that time with your healthcare professional, again, whether you're talking to someone, a social worker or an advanced practice nurse or an MD or a DO, to just make that time most effective and most valuable and worthwhile. So just write it down, make a list, and make sure you have the questions that you want to have answered for any kind of follow-up care or concerns that you might have about some vague symptom, and that would maximize or optimize the time with the healthcare professional. So telehealth certainly is, in my view, here to stay. It was, again, very limited use for the most part. I think Kaiser Permanente, one of the largest clinical organizations in the country, as well as being an insurer, so they have sort of two parts to the Kaiser enterprise, are getting upwards of 30% of all of their visits now by remote care, and they anticipate that to continue beyond the SARS-CoV-2 pandemic. So I'd say, again, if you are personally comfortable with that kind of interaction, then it can be highly effective. And this is on me as a healthcare professional, and I still see patients one afternoon a week, and some of that work that I do is remotely. So we healthcare professionals need to learn something called webside manners, which is a bit different than bedside manners, but has a lot of similarities. So that's on us. And again, you as a consumer or patient also need to think about how to best make use of the time that you have with the healthcare professional in a virtual visit. So it's a powerful tool. It's effective. It's not a substitute. And one quick other anecdote: one physician told me about someone that he was talking to, and he, based on certain things that the woman, it was a woman, was the patient, said, he was extremely concerned. And he said, "You better come into the office." And he hadn't seen it in like 20 years, and she had something called toxic shock syndrome. So it was very astute of him to have this woman come into the office. Actually, my deceased father-in-law, who was Tony Fauci's mentor, yes, Dr. Fauci, Shelley Wolf, was one of the first people to talk about and define toxic shock. So again, telehealth can be a very effective adjunct to your healthcare journey, whether you have ovarian cancer or the risk thereof, whether you have breast cancer or the risk thereof, if you're a survivor, but it doesn't necessarily totally augment or substitute for in-person care. And the last thing I'll say is there's a lot of also interesting and important, exciting. I've got a little device behind me, Melissa, from an Israeli company called LiveCare, which allows for uploading of a lot of information very fastly from obviously with your permission, to your healthcare professional, your pulse ox, your blood sugar, your blood pressure, your temperature, and electrocardiogram rhythm. So there's a lot of exciting things happening as well in what's called RPM, remote patient monitoring, which again juxtaposes to telehealth. So with that, I'll turn it back over to you, and I'm sure we'll have an animated conversation.
Absolutely. Thank you so much for that. It was a great introduction to how telehealth can be used. We have a lot of questions. I've taken the liberty of combining some that were very similar, but maybe the first one to start is one that really has both an insurance and a medical component to it. So if we could pin both of our presenters, not me, but Joanna also. There we go. Okay. So one of the questions that came in was, what is the biggest challenge you're hearing from survivors regarding healthcare? And I want to add to that I've personally spoken through my work at Triage with survivors who have been offered telehealth follow-up appointments and have not been happy with that, right? Because we're used to, as survivors, being seen to make sure there are no lumps, there's no swelling, there's nothing unexpected. When she pushed back, she was told that she would do this now, she would do the telehealth, but when things calmed down, she wanted to come in for her regular follow-up. She was then told that insurance would not pay for that because it was an added appointment. And so this really is for both of you in terms of, when do we advocate that we want to be seen if there isn't an overwhelming medical concern at the moment? And what can we do if insurance isn't covering changes to our normal plan based on COVID and the pandemic? So Dr. Peskin, you want to go first and then we'll hear the insurance side of it?
Yeah, and I can't help but speak to the insurance side of it, working for a single state Blue Cross Blue Shield plan. So if one wants to be seen, as Joanna well described in the metallics, the Obamacare, silver, bronze, platinum, gold, one can be seen. Now, sometimes there are difficulties getting an appointment. And that's a reality. That is not on the insurance company. That is on the cancer center, whether it be Hackensack John Thor or Carol Simon or Rutgers CINJ or
any throughout the country, I would assume.
or MD Anderson or whatever. Yeah. So, but your insurance is not limiting your ability. Again, Joanna may take issue with this. There are costs. There's something called patient cost burden that Joanna mentioned, but you are not excluded from seeing your medical oncologist, your radiation oncologist, your advanced practice nurse that works with you. You are not limited in that way at all. I'm not familiar with any health insurance saying that you can't have a follow-up visit because you want one. There are limitations sometimes on chiropractic. There may be something called prior authorization for advanced imaging, for example, PET CT. But if you want to see your, as far as telehealth goes, if that is what the clinical organization, we'll call it a cancer center, we'll call it even a comprehensive cancer center, has offered you, and you respectfully disagree with that, then you really need to, in my opinion, advocate for yourself and say that I really want to be seen in person. On the other hand, telehealth can be very effective in terms of, just as we are seeing one another on this wonderful Zoom platform, and can be quite satisfactory for many types of issues.
Got it. Joanna, in terms of...
I don't have anything to add. I would have said the same thing.
Okay, then. Well, let me ask a related question. This one I really will throw your way, Joanna. So we know, especially at the beginning, and I suspect it might happen again as we're entering our third wave or whatever wave it is of COVID, sometimes people who have active cancer, their treatment plans were changed because of risk. Maybe they were taking oral drugs instead of going in for infusions. Maybe they were taking oral drugs to keep things in check until it was safe to go into surgery. Any number of changes that might have been made. These are outside of what is considered the normal treatment, but necessary based on what's going on in the world. Have there been any concerns with payment for things that an insurance company might not normally pay for, but that are medically necessary because of the pandemic?
We haven't seen that. I think all of those potential changes to treatment plans are about mitigating risk. And we now live in a world where everything we do is about assessing how much risk we want to take. And so healthcare professionals aren't going to risk someone's health related to treatment plans. And so those treatment plans are still going to be based on what's medically necessary, and that's the legal standard for insurance. So as long as the care is still medically necessary, insurance companies, they might try to argue that they don't have to pay for it or they don't want to pay for it. But that's why I shared the information about the appeals process, because we think that that is key. So it is incredibly important, and unfortunately one more step that patients have to take to advocate for themselves. But if patients know that that's available to them and communicate that to their health insurance company is less likely to continue to deny coverage for any type of care that's medically necessary.
Thank you. You know, you mentioned it's all about mitigating risk, whether we're on the medical side or the insurance side of healthcare. So for those who are cancer survivors or who are not, but carry genetic mutations that lead to higher diagnostic risk, can you speak, Dr. Peskin, to the wisdom of proceeding with annual screenings, whether they be in a hospital, a doctor's office, a lab, when they're screening tests as opposed to diagnostic tests with regard to risk of COVID?
So any interaction outside of your bubble, your pod, and I'm here with my wife and daughter, and we've been exposed to one another. And so so for screening mammography, for screening colonoscopy, there certainly is some risk. I can't give you an exact percentage. Certainly healthcare professionals are exceedingly aware of. When I'm in clinic now, I wear both a mask and a face shield and gloves in the room with the patient, dispose of the gloves after each visit and wash my hands. So a screening intervention does not have zero risk, but almost anything in life we do, I mean, getting in your car doesn't have zero risk, quite honestly. Obviously having a procedure when they scare the bejesus out of you with all of the, risk of infection, risk of disability, risk of incontinence, risk of death.
Okay.
So I would say screening does have risk associated with it. That risk is mitigated by what you do as the patient. That risk is mitigated what the healthcare professionals do, but it's definitely not zero. So you have to, that's a very much an individual choice. Certainly, you didn't ask me about vaccination.
That's the next question.
Hopefully there are no anti-vaxxers on the call. We certainly should be getting, if you're of age to get Pneumovax 23, or in cancer, there are reasons to get certain vaccines accelerated. having had shingles myself, including when I was in Israel, I can tell you shingles is absolutely awful. So if you're over 50, the Shingrix vaccine is available to you with most insurance plans, including Horizon. And so I would say, you know, that to me is worth the risk to have that intervention. If you're at exceedingly high risk because you're under treatment with active chemotherapy, then you may want to wait. And obviously there are certain things, again, that oncologists know infinitely better than I do about the timing and sequencing of things related to individuals under active cancer treatment.
Well, so we talked about, because the question was for people who are either into survivorship or are at heightened diagnostic risk. And you said it's a cost benefit analysis, right? You have to just weigh the risks and the positives, the benefits. Obviously that changes what changes the equation is if somebody is having an ambiguous symptom and the symptom and the test becomes diagnostic, in which case, surely a conversation should be had with your doctor, but it would likely be determined that a diagnostic test has more urgency to it than a screening test. So that's something to keep in mind. Dr. Peskin, you mentioned inoculations, vaccinations. And although this is not exactly the topic of tonight's presentation, I would like to ask you, because several people did ask about it, are cancer patients and survivors considered a high-risk group, prioritized when a COVID vaccination becomes available? Or is it possible that those in active treatment won't be able to get the vaccination during that treatment at all? And we may not know the answer to this, but any insight you might have, there was definitely interest in this topic.
Yeah, that's a great question. I wish I knew the answer. I don't know.
Right.
Certainly high-risk populations, older persons, persons with COPD, persons with congestive heart failure. We no longer use actually congestive, we just call it heart failure, are at higher risk. So individuals living in assisted living and nursing homes and so forth, so they would be considered at higher risk. I think the rubric is healthcare professionals, active healthcare professionals seeing patients, essential workers, high-risk persons. I believe that's the current rubric, but I could be wrong about that.
It's going to vary a little bit from state to state too.
Yeah,
Right.
thanks.
I guess this is information we'll have to wait on because not even all of the experts know it yet. Let me ask one more question before we look to finish up. And if anybody has any questions that I haven't addressed yet, please, this is your chance to put them in the chat. But you all did such a great job of sending them ahead of time. But this one is for Joanna. What do you tell patients who need to work for financial reasons and to maintain health insurance, but working is taking a toll on their health?
I think that is a very practical and unfortunately common question. I think it's important to understand what your employment rights are and how you can use reasonable accommodations under fair employment laws like the Americans with Disabilities Act or a state law that can help you continue to do your job. I really recommend that someone ask for an accommodation as soon as they realize that they need one, because if you are suffering through side effects and it does affect your job performance, and the only information that the employer has is that your job performance has suffered, then employers can make employment decisions based on poor job performance. And so reasonable accommodations are there to help people. And they can range from, being able to work from home because you have a compromised immune system to an ergonomic chair or your desk or a parking spot that's closer to the building so you're not walking as far. There are all sorts of accommodations. And we think that this is probably the most underutilized tool when it comes to employment issues for patients. So we have a lot of resources on reasonable accommodations on our website and how to navigate them.
That's great. Thank you. Someone here was saying that on the chat that their chemo was delayed because she was exposed to COVID. And yes, so there's a lot of changes being made. By the way, we don't have time for any more questions, but I will say there were a lot of specific questions about, do you think it's safe to do this? Do you think it's safe to do that? Like, for instance, integrative services like lymphatic massage or acupuncture that people know they would help them, but they're afraid to give themselves an extra potential exposure. Or they need to get into a car service to go to treatment, but they're worried that being in the car with someone will expose them. So each one of those things has to be an individual decision based on what the risks are and what the benefits are. You know, we could talk for another hour, but we are not going to tonight. I do want to thank Joanna Morales of Triage Cancer and Dr. Stephen Peskin for sharing their expertise. I am sure it was as helpful for all of you as it was for me. I learned a lot from both of you. I want to thank our sponsor for today's webinar, which was the Sigmund and Edith Blumenthal Memorial Fund. You know, somebody where the questions were meant to go actually made a comment that I want to share. Someone had a lot of questions and then they finished, some of which we covered tonight, but then they finished with, it's really lonely being sick during a pandemic. And it's really true. And so I just want to remind you again that Sharsheret is here for you and your loved ones during this time. We provide emotional support. We provide that one-on-one support programs to help you navigate this experience. And it's all free, it's all private, and it's so important. You can, if you would like, reach our clinical team by just emailing clinicalstaff@sharsheret.org. Even if you don't know what you need, even if they don't know, you don't know what you need, they can help you figure it out. And I wanted to let you know also that we are putting an evaluation link, a very brief evaluation link. It's right there now in our chat box. Please take a moment. It should take you right to the link. We really use our evaluations to plan future programs. And so it would be very helpful to us, if you would do that. I want to thank you again for joining us, and I want to wish you all a lovely evening. And if you have any other questions, you can always reach out to Sharsheret in any way, through the email address that was there or by going on our website and contacting us that way. And we look forward to seeing you at future events and webinars. Thank you very much and good night.
Thank you, Melissa.
Thank you.
Good night.
Night.
Well, everyone.
Thank you.